Okay, so I'm hoping everybody is logging on. I want to welcome everybody to this webinar presented by the Columbia College Women and Columbia Engineering Young Alumni. I am Dr. Tamara Takutis. I am going to be the moderator for our webinar tonight. We're excited to bring this expert panel to you to discuss some very important emerging topics and expanding area of technologies. Afterwards, we're going to have a Q&A session, but after the Q&A session ends, we're going to invite you also to a chat with some of the Columbia College Women volunteers and other women who might want to have more personal conversations about fertility. So thank you everybody for joining us tonight. Each speaker I'm going to introduce, and each speaker is going to have about 10 minutes, and I'm going to introduce them one at a time. And as we go through, if you have some questions at the very end, under the Q&A, we're going to have you ask some questions. So thank you everybody for joining us. The first speaker tonight is Jackie Harunian. Jackie graduated from Columbia College in 1991. She's been practicing law for 25 years. Right now, she is the managing partner of Wieselman Harunian Family Law. Jackie's rated as an AV preeminent and twice named Super Lawyer Top 50 Women Lawyer in New York. Her very unique multidisciplinary background, including a graduate degree in behavioral forensic psychology, enables her to handle complex divorce, custody, and asset distribution matters, including prenuptial agreements, religious and cultural issues, fertility law, and same-sex divorce matters. There have been some profound changes in relationships and gender roles over the past decade, and new changes are on the horizon due to our pandemic. Jackie's devoted to helping individuals and families navigate transition with a holistic approach to conflict resolution and co-parenting. So I'd like you to welcome Jackie to give us some words of advice.
Thank you very much, Tamara. I'm very excited and grateful for this opportunity to present for Columbia University and the college. I appreciate everyone who helped put this panel together, and I know it's going to be a really interesting discussion. As you mentioned, I am the managing partner of a high volume practice in New York. And since I've been practicing for so many years, I've been really in the front row seeing all the very many changes in relationships, in families, and in the law over the past few decades. And there have been very dramatic changes in gender roles and expectations, and very different from what our parents and grandparents expected when they started relationships, got married, and formed families. Approximately 10 years ago, New York State became the last state in the country to adopt no-fault divorce. And there has been a lot of changes in divorce, in custody, and in parenting since no-fault was passed. The most dramatic change is we now have, finally, gender-neutral laws regarding custody. And this has been a very big change, not only for traditional couples, but also couples who are not married and same-sex couples. And there have been a lot of trends that have gone along with that, that really are the reason why we now have no-fault divorce. And all of those trends have sort of been accelerated since the pandemic. And hopefully now we're in the later stages of the pandemic, but we're seeing a dramatically lower rate of marriage in the United States, a very, very low rate, a birth rate in the United States, but also, encouragingly, a lower rate of divorce. And the reason for that is that millennials, we all love them, they're marrying later, they're very enamored of prenuptial agreements, they have much more of an egalitarian view towards marriage and relationships and money, and they are choosing better partners, and are very, very interested in changes in ways to create families. So now in my office, every single day, we're getting calls about surrogacy contracts. You're going to hear about today how we can actually have surrogates, IVF technology, ART, advanced reproductive technology. Every day, we're getting calls about egg donor agreements that fertility labs are now requiring parents to sign off on regarding the storage of eggs, frozen embryos. We're doing a lot of sperm donor agreements. So many things that were unheard of only a few years ago have now become mainstream. And I find it very encouraging in my practice that the topic of infertility, which used to be so painful and really would lead to divorce in many cases, a lot of times because it's so costly and wasn't covered by medical insurance. Today, in many, many cases, it is covered by medical insurance. And people are very interested in talking about fertility and infertility very openly. And now, most often on Zoom, I'm sitting with couples who are talking about it and are creating a plan to become parents together for same-sex couples as well. So it's very nice to see the shattering of stigmas. That really is the new frontier in family law, that almost every topic that was shameful and secretive is now out in the open in a much healthier way, including women breadwinners. They're all over the place, and they're very interested in surrogacy contracts as well. They sometimes have careers, or they're a little bit older, maybe didn't think they would become parents or have a second child. And now those possibilities exist for older parents, career women, and that's very exciting. So the new paradigm of parenting, the starting point for families, for parents, whether they are married or not, is joint custody. There are more fathers that have custody than ever before. They are coming to our office requesting joint custody, 50-50 custody. Again, this is something 5 or 10 years ago was an anomaly. And today, this is what couples expect when they are raising children together. There's also a big emphasis these days on shared parenting agreements, written agreements. I mentioned prenuptial agreements. Couples are much more willing to put things in writing, and this is very, very necessary, especially for parents that are not married, and especially when there might be some question about who the biological parent is, who the legal parent is. When you have things in writing, especially since the change of the law that occurred, the most recent one is in February 2021, when surrogacy contracts for the very first time in New York State are now being allowed with compensation. So this is a game changer. This is up until February 2021, it was not allowed. And so now, because these surrogacy contracts are allowed, you can have contracts for compensation, and you can also have something called compassionate surrogacy contracts where you don't have to have compensation. After parties enter into an agreement about how the egg or the sperm or the embryo is going to be created and implanted, then you need to go to court with something called a pre-birth order and have the order signed off on by a judge, and then the names go on the birth certificate. This is all brand new. A lot of family law practices are not really doing them yet, but more and more there is a demand for these surrogacy agreements. And it's very, very exciting for parents that up till now could not have become parents without this medical and legal technology. The other important thing is agreements regarding storing embryos, destroying embryos in some cases. It's very, very important that all of these things be in writing. And most reputable IVF clinics and embryo storage facilities are requiring donors, requiring parents to complete what's called a disposition agreement, which will instruct the IVF clinic or the storage facility on how to handle an embryo in the event of divorce or death of the parties. And this has always been a big issue for litigation, and now, thankfully, this is going away. So I know my time is running short, and I'm very excited to hear about all of the medical possibilities and advances from all of the doctors on the panel. I just want to leave on a very positive note how wonderful and hopeful it is that these stigmas are falling away. And we're now here talking about it openly. There are so many wonderful possibilities post-pandemic, with everyone sort of was stuck at home and quarantined, and now they're going out and creating relationships and families. And I'm very happy to be part of this discussion tonight. Thank you very much, Tamara.
You're on mute.
Thank you. That was awesome, Jackie. Thank you so much for that insight. I completely breezed by introducing myself. I apologize. So I just want to take 1 minute to introduce myself because I come from a different breed of physician. I am a maternal fetal medicine specialist, and I've been practicing high risk obstetrics in the Boston area at Beth Israel Deaconess Medical Center and now in private practice. And I used to run the Joslin Diabetes and Pregnancy Program. I now consult for all of the Cape Cod healthcare system and the South Shore medical system. And I also work part-time at Emerson Hospital. So I graduated in Columbia in 92 and Columbia Med School 97. And I did my residency at Beth Israel in Boston. And then I did my maternal fetal medicine fellowship at Brown. So I take care of all of these patients that we're talking about tonight once they're pregnant and achieve a successful pregnancy. And I do a lot of counseling before pregnancy to try to ferret out some of these issues that we're talking about. So with that, I would love to introduce Dr. Linnea Goodman. And we apologize that some people can't see her name that's blacked out, but she's not trying to hide her identity. We guarantee that. Dr. Goodman's a board certified reproductive endocrinologist and infertility physician at Virginia Fertility and IVF, and she's an assistant professor at the University of Virginia. She earned her undergraduate degree of biomedical engineering with honors from Columbia School of Engineering and Applied Sciences. After that, she pursued medicine at the University of Vermont College of Medicine, where she got her medical degree and received numerous awards. She completed her residency training at OBGYN at the University of North Carolina Hospitals. And then she went on to do her reproductive endocrinology and infertility training at the Cleveland Clinic Fellowship Program. Her research during her fellowship received national recognition, earning her research grant funding from multiple distinguished foundations. Since graduating from her fellowship in 2016, Dr. Goodman has practiced in both private and academic settings, with a special interest in cost-effective medicine and incorporating new technology. She continues to be a productive researcher with the goals of excellent patient care and advancing the field of reproductive medicine.
Thank you so much for that introduction. I'm really excited to talk to everyone tonight. I think, the best introduction that I could have had is, talking about millennials. Technically, I graduated from C's in 2005, so I am on the very tail end of the millennialship. I don't admit to that often, but the reason I bring it up here is because I think in my training over the past, the 16 years of training and then the 6 years in practice, I have noticed a complete shift in our field with these people that come who are savvy with social media and the internet, and they come to see me with all sorts of different preconceptions than they did 10 years ago. It used to be that someone would show up in the office and say, I'm trying to get pregnant, I've tried for 2 years, what should I do? And now they show up and they say, I've tried for 7 months. I've tried modern fertility tests. I've done my AMH testing. I've done these supplements. I've done this X, Y, and Z. And now I need you to fix this. And it's a totally different landscape. And so my goal tonight is to kind of talk through how to optimize natural fertility and how to navigate this space while you're trying to conceive. And so that when you show up to an REI's office, you have an understanding of basic fertility and then also what we have to offer. So I'm going to share my screen here. Let's see if this works. All right. Can I get a thumbs up from someone if that looks good? Perfect. Okay. So I am going to start with, let me see. Here we go. So let's start with a little physiology. And this is something that I go through with patients on a daily basis to kind of understand how I could have been a menstruating woman for 20 years and not understood what was going on in my body and how to monitor these hormones. So we have the brain, we have the ovaries, and we have the uterus. And in the beginning of the cycle, we release this hormone called FSH. And every month, our ovaries bring up this group of follicles. And within this group, one becomes dominant and the rest die off. And the next month, another group comes up, one becomes dominant and the rest die off. So this dominant one starts secreting estrogen. And then that estrogen talks to the brain and says, brain, I've got my puppy. I don't want to litter puppies. So can you please stop making FSH? So the brain shuts off its FSH, and now you have this one dominant follicle that makes more and more estrogen. And when it hits a certain level, it then talks to the brain and says, brain, I'd like to ovulate. Can you please make me some LH? Brain makes some LH. About 36 hours later, we're going to have this ovulation. And this LH surge is what you test for when you use an ovulation predictor kit. So we have this surge, you ovulate, and now you have what's called a corpus luteum. And this corpus luteum makes progesterone, and this lasts for about 12 to 14 days. And then that dies and we lose progesterone. So the ovaries are very smart. We do this every month. The uterus, on the other hand, not smart at all. So we've got the uterus, and when it sees estrogen, it builds a lining. When it sees progesterone, it builds a stable lining for an embryo to implant. And then when you lose progesterone, then you shed a lining, get a period. Now, what do you need to get pregnant? So in theory, it's very simple. We need eggs, we need to ovulate those eggs, we need sperm, and then we need a place for them to meet. So how do we test for these things, and how do we determine where you're at in a sense of fertility? So one of the biggest things that we can test for is egg quantity. Now, we know that as we get older, we lose both egg quantity and egg quality. And it's very shrouded in mystery, and no one tells us when we're in high school health class, when they always tell us how not to get pregnant, but no one tells us how to get pregnant. And so the average age of menopause is 51, but what not a lot of women know is that most women are unable to have children with their own eggs after the ages of around 42 to 45. I have many women that come to see me at 45, 46, and they say, okay, I'm ready to have a baby now. I don't know why it's not working, without realizing that even though you're still menstruating, the quality of that egg may not be good. So how do we test for ovarian reserve? There's three main tests. The one that used to be most popular is an FSH level. That has really gone out of favor. And the two others that we can do routinely would be an anti-Mullerian hormone, or an AMH level, as well as an antral follicle count. So we talked about that every month there's a group of eggs that comes up, and out of those group, each of those little guys secrete this hormone called AMH. So this gives me an idea of how many eggs are in this group that are coming up. But it's important to note that AMH does not predict spontaneous conception. So if I have a 32-year-old with a low AMH, that doesn't mean that she can't get pregnant. It just means that group of eggs is smaller. But AMH does predict the response to fertility medications such as IVF. So what is IVF? I talked about earlier that the brain releases FSH to bring these follicles up. One becomes dominant, that one stops the rest of the follicles. What IVF is just giving women FSH and making all of these follicles in the group come up. That way we have this whole wave come up. We can then take these eggs out, and that's how we can either preserve fertility or go about doing IVF. So AMH level does predict that. It is not cycle dependent, which means that you can measure it any time in the cycle, but it does fluctuate some. Now, this is a test that people can now order over the internet with these, online fertility evaluators. And so this business has kind of changed the way that it works. I'd say probably 5% of my patients come in having some sort of test off the internet that defines their natural fertility. We talk about this. So a normal value in my office would be greater than 1. This correlates with what looks like on ultrasound. So you can see here that these are 3 pictures of different ovaries. The one on the left has someone with a high antral follicle count. The one in the middle would be low to medium. And then we've got the one on the right, which is a low antral follicle count. And this correlates with AMH because the more follicles you have, the more AMH you make. And so we can see this on ultrasound as well. So then we have to make sure you're ovulating. And you may have heard of things like basal body temperature, cervical mucus. The biggest thing for me to tell if someone is ovulating is to see if they have a normal, predictable menstrual cycle. If someone has a normal menstrual cycle, that tells me that they are ovulating. And there are over-the-counter ovulation predictor kits. These measure LH in the urine. And so it can tell when you have this surge that you should be ovulating within the next 24 to 36 hours. We can also check a progesterone level in the second half of the cycle. And that tells me that you've made that little cyst called the corpus luteum, that you're making progesterone. There are things that can throw off ovulation, such as thyroid disease, prolactin disease, or PCOS. And these are things that we can test for as well. So what are the things we test for when you come in for a fertility evaluation? We test for sperm. And the biggest thing that I'm looking for was something called a total motile count. So the number of sperm that are moving in the sample. And then we also check the uterus and the tubes and make sure that we have a working conduit for the egg and the sperm to meet. And these tests are such as an HSG, where we put dye through the tubes and see if they're open, or a SIS, where we put saline into the uterus to make sure there's no polyps or fibroids or things like this. So let's talk about fertility down to basics. So the chance of getting pregnant per month under the best of circumstances, so say a young woman age 25, we're talking 20 to 25% per month. And that's mainly because human beings are just not very good at getting pregnant. We don't have the same fecundity as cows or pigs or rabbits. And so we really just have less of a chance than a lot of other species. With that fecundity rate, about 85% of young couples will conceive within the first year. And so let's say I have 100 couples, I send them out into the wild to try and get pregnant, 85 of them get pregnant. Of that 15 that are left, the chance of getting pregnant per month is about 3%. Now, that is pretty low when you think about it, when you've got someone that's been trying for a year. And so there's lots of things we can do to try and augment this. And that's where our fertility technologies that we're going to be talking about are coming at. We're trying to bring up number of eggs, or isolate the good sperm, or put the sperm and the eggs together in such as IVF. So one of the big problems is that as we get older, not only do we have less eggs, but we have less good quality eggs. And so the percent of what we call aneuploidy, or the embryos that are abnormal, rises significantly as we get older. And this is going to be a big change as more and more women are getting older trying to get pregnant. We're going to see more and more embryos being abnormal in this IVF process. So what are some good resources for people as they're trying to conceive naturally? This is our practice committee. The American Society of Reproductive Medicine has a great article talking about optimizing natural fertility. And so what I tell patients, most of the time patients when they've got to me have already gone through this, but in someone who's initially trying to conceive, there's a lot of gray area out there and a lot of things that the internet are telling us to do. But basically what it comes down to is figuring out when you're ovulating and having sex every other day around the time that you're ovulating. There are some factors that can affect this. And all the time I have people that come in and they say, okay, Linnea, what can I do that helps my chances? The biggest modifiable risk factors that I see are obesity and smoking. These are the two big modifiable risk factors. So we want someone to be of a normal BMI under 35, no smoking, alcohol less than 2 drinks a day, and less than 2 cups of caffeine a day as well. And then timing of sex is something that a lot of people talk to me about. And the key is before ovulation. And there's a lot of myths that you have to have sex twice a day or every day, but really every other day is just as effective as every day around that time of ovulation. So some common myths to bring up with this. So all the time I get people that bring these tests to me that say, I've checked my progesterone and my estrogen in this kit that I get, and it's too high or it's too low. But you cannot reliably check progesterone and estrogen levels in the saliva or urine. And so I wish we could, because it would be amazing in my office if we didn't have to draw blood every day. But so if we have these tests, these ones are not as reliable. There's no beneficial coital practices or laying down after sex that are helpful. And one big one is that if you have irregular cycles, you don't have to wait to see a specialist, because if someone has 60 to 90-day cycles, they're not going to be getting pregnant. And so we can definitely help you ovulate faster. A fun one that I like is there's no way to predict if you're having a boy or girl based on the timing of sex or how you're carrying a pregnancy. I wish there was, that would be great. And there have been no supplements that have been definitively proven to benefit for male or female partners. They're all over the internet. I have many people, vitamin D, free fatty acids, coenzyme Q10, vitamin C, E, and certainly a multivitamin can be helpful, and definitely a prenatal vitamin for folic acid. But if it makes you feel better to spend a bunch of money on supplements, fantastic. But if that's not something that you need to, there's nothing that you feel like you need to be taking. All right.
Dr. Goodman. Oh, that's perfect timing. Excellent.
Perfect. So I'd love to turn it over and get into more technical aspects. Thanks so much.
Excellent. Thank you so much for that. So I really am looking forward to introducing Dr. Mark Sauer, who's our next speaker. And Dr. Sauer is an American physician who specializes in also reproductive medicine. He's a clinician, a researcher, a medical educator, best known for his work in the development of egg and embryo donation, fertility care of HIV seropositive patients, and reproductive bioethics. He is currently the professor and chairman of obstetrics, gynecology, and reproductive services at Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey. He also serves as the senior associate dean for women's health there. Dr. Sauer was the chief and the division of reproductive endocrinology at Columbia University for 21 years, where he also was the program and lab director for the Center for Women's Reproductive Care and a tenured professor and vice chairman in the Department of Obstetrics and Gynecology at the College of Physicians and Surgeons at Columbia. While at Columbia, he also served on the Medical Ethics Committee of New York Presbyterian Columbia University Medical Center. So I welcome Dr. Sauer to give us his insight about these technologies going forward.
Yeah, thank you, Tamara, and thank everyone for putting this panel together. It's always a spirited and usually heterogeneous discussion, depending on your viewpoint. I'm going to try to hopefully share my screen here, and I'm going to breeze through a lot of slides covering 44 years of in vitro, okay, in 8 minutes. So bear with me. I hope I don't make people seize or something. But I thought I would take a different slant. The slant I'm going to take is someone who's practiced in the field for, I hate to even admit it these days, 36 years. I've seen tremendous changes. As Lance said, I have a slide that I don't use today saying this, it's not your father's IVF. I've actually got 2 residents who are IVF babies, which is fascinating. So those in the audience that are under 40 don't know a world without in vitro. The older guys still see it, I think, as something really quite astonishing and magical. So again, I'm going to give you a quick overview of how we got here. I was very, very privileged to meet and work with Robert Edwards. He's the gentleman holding Louise Brown in the picture there. And it was an interesting collaboration, a basic scientist who worked for many, many years to figure out how to fertilize and how to grow embryos in culture, working with a nurse in the middle, Jean Purdy, who rarely gets credit, but she was the embryologist, and Patrick Steptoe, a gynecologist who had access to women and their ovaries, eggs, basically, right? Fast forward, 10 million babies born to date. I mean, it's phenomenal. Again, I learned IVF in the mid 80s, where if we could get anybody pregnant, we felt really good. I was at UCLA and USC, and it was a very different time in terms of success rates. Nearly 2.5 million cycles annually in the world now, 500,000 births yearly. What was alluded to earlier, I mean, 1% to 2%, I think it's probably closer to 2% of American babies are results of ART now. If you'd have told me that again 30 some years ago, I would have thought, no, that'll never be that good. And these are reported by the CDC, as you can see, 330,000 cycles in the last report in 2019. So IVF from the very beginning was just a world event, very controversial, kind of a closeted experiment that hit the stage with the announcement of her birth. That's the world press, believe it or not. They're holding a press conference there, Bob and Patrick. So a very different world, but again, it caught a lot of attention when this hit the press. And luckily for us, meaning medicine, and I think really society at large, we had someone who had actually pretty good training in bioethics. Bob Edwards actually spent some time studying locally with several theology people. And he was a very serious student of medical ethics. And again, he could see it very clearly, this interface between basic science and clinical medicine, and how a fundamental question of how society would view embryos and ultimately fetuses. So a quote from his book, "Complexity of the questions can divide a nation." We know that's true. And he had the clairvoyance to see that in very early stages. As I said, I met Bob in the early 90s. That's me with brown hair up there. He was about my age when I met him. And we developed a quick friendship, largely because I spent a lot of time on farms as a kid, and he loves goats and sheep. And so we immediately bonded over these kind of topics as opposed to IVF. But he also liked my kind of rebellious nature, making menopausal women pregnant, so forth, because that was in line with his general philosophy of access and opening things up to people who need. I later, just a few years ago, had the privilege of meeting Louise Brown at the bottom there at a dinner. So I kind of did the whole circuit there, and it was really, really fun to know these people. So I want to focus on a couple of things that was touched on, but these problems that are increasing in numbers. We have an epidemic of infertility in this country, but also in Europe and other places. And I would argue it is partly because of good social changes and the evolution of how women view themselves and how their role in society. So we now have, and have for 50 years, effective, accessible, and affordable contraception. We have legalized abortion. Women are pursuing their education, pursuing vocation. They want autonomy. They don't want to depend on somebody who's usually not that dependable to support them and take care of children, for instance. As mentioned earlier, later and fewer marriages, and I think it's still fair to say increased divorce compared to decades ago. A lot of STIs out there. We know more about reproductive toxicities, and a lot of people are surviving their cancers. That's a good thing, but at the price of ovarian damage or sperm damage that affects their fertility. So these things all impact, and we know, as this caricature shows, you've seen this. Evolutionary biology does not always recognize these social changes, right? I mean, we still came from these primates, and people hate this slide, but I still like it. It's true this way too, because of these social changes. So women are deferring reproduction, and they're able to do that very effectively, again, because of available and accessible contraception. So by the time they are in a really good position to seriously take on the challenge of pregnancy, it can be too late just from a strictly biological point of view. Nobody's fault. They often appear to me to be feel somewhat victimized. I try to take that burden off their back when I see them, but it is problematic. This is an example of not that recent now, but New York Times piece to illustrate that. Successful real estate person in Washington D.C. Trying to just basically decide, well, I don't want to give up my career here. I'm doing really well. So how am I supposed to do this? How am I supposed to have a baby now? And nobody really has a good answer for that. Now, again, these are natural phenomena, as Anna mentioned. We probably weren't meant to live so long, to be quite blunt, because fertility actually starts to fall off in the population, typically in your early 30s, pretty dramatically by your mid 30s. You start to see increasing, severe subfertility. Basically, people out. Sterility is kind of permanent. That's a retrospective diagnosis. But you start seeing people really struggle by 40. Once their cycles become irregular by your mid 40s, it's pretty much over in terms of using one's own eggs. Menopause by 50, people are used to that. And I see this all the time where my patients for decades will say it's just not fair. And I remind them, well, we basically came from primates. And if you don't believe it, just look at a chimp ovary. You'll see the exact same histology as the chimp ages as human. You couldn't tell one from the other. And as mentioned with antral follicle counts, you see this diminution of available developing preantral follicles and antral follicles over time. So that along those lines, as all of us primates age, these things are inevitable, and there's no getting around it. There's no stopping. That's a biologic clock, which again has fallen on as a term now that's being criticized. But I've argued with our students who voiced a criticism of a biologic clock slide that somebody in my department used, that I would argue we all have biologic clocks. If you don't believe it, go to your local cemetery and take a look. Now we see this in and I can show you many, many slides on many, many therapies, but this is one, I think, from probably 10 years ago. It has not changed. The success rate of in vitro pregnancy rates or live birth rates fallen off pretty much in line with those natural aging graphs I showed you. By the time you're in your mid-30s, pretty dramatically. And this relates to what was said earlier about the increasing amount of abnormal eggs that are being recruited, leading to abnormal embryos that either don't implant or miscarry. Now you'll notice that red line is the egg donors who are typically in their mid-20s, they're at a good time to undergo these kind of therapies, and they're producing a lot more, normal eggs to work with. That's why the success rates using donor eggs, even with older patients, stays very high. All of us are really aware of an onslaught of the commodification of egg freezing. I have mixed feelings about it. Several of my trainees from Columbia have been very successful in setting up businesses. They just focus purely on egg freezing. When I was in San Francisco doing a year before coming to Rutgers, I saw, Facebook, Google, others with covered benefits for egg freezing, and people were definitely using the benefit. The question is it ethical? Is it a good idea? And the answer is it depends. It's not so easy to tell you. It's all about the number of eggs and the age of the patient. Now, this is a graph that was based upon analysis of theoretical blastocyst formation and euploid embryo formation based upon age out of Harvard. But what it shows, I think, illustrates nicely that if you're young, under 35, you probably need somewhere between 10 and 20 eggs to have a reasonably high chance of a live birth in one of those cycles that you've gone through. But what about the more common 40-year-old who now comes? And as you can see, you need a lot more eggs, mature eggs, to get the same kind of success, and you actually never attain that, you never reach it. And on top of that, most older women, again, over 35, certainly over 37, they're not producing a dozen eggs at a time. They're more likely producing 5 or 6, maybe 7, and so again, it's a problem. So keep in mind what we're talking about here. I'll really speed up quickly. This is IVF again, is mechanical, it's technical, it's everything outside the body. As you can see there, we suck the eggs out, we find them in a dish, we put them, fertilize them, we put them away. These are the basic component parts that was alluded to, and all the programs do it. Increasingly nowadays, we freeze these products and again, biopsy the embryo and put them back, so we get much higher success rates than we used to. We're basically mimicking what happens naturally in the fallopian tube. The purpose of this latest CDC slide is just to show you a couple of quick things that are very different than it used to be. Number one, percentage of frozen embryos has taken over because we now freeze things away and put back less, either based on morphology or biopsy. But you'll notice too, on that second column, that live birth rates again fall pretty precipitously as the women get older. I'm just going to say a couple quick things about ethics. Why is this such an ethical quandary? We're dealing with embryos, the status of the embryo, the high-tech artificiality. Biologic naturalism bothers people. You can't tell a mouse embryo from a human under a microscope. That bothers people, and so forth. So, and as was mentioned earlier, legally, the definition of parenting is evolving all the time, and it's being defined more and more legally, which is helpful. And I think that yes, that's my last slide. So I'm sorry I ran a little over.
No.
But again, I'll get rid of my screen. There we go.
Oh, thank you, Dr. Sauer. That was an excellent compliment to Dr. Goodman's presentation too, because that is an amazing history to see where we've come in the last 44 years. So this leads us to talking to Dr. Klitzman, who's our last excellent speaker tonight. Dr. Klitzman is a professor of psychiatry at the College of Physicians and Surgeons and the Joseph Mailman School of Public Health, and the director of the online and in-person bioethics master's and certificate programs at Columbia University. So this is a great lead-in. Dr. Klitzman has written over 160 scientific journal articles, 9 books, and numerous chapters on critical issues in bioethics regarding genetics, neuroscience, psychiatry, doctor-patient relationships, and coping with illness and other areas. If you would like to see some of the list of Dr. Klitzman's books, just look at the bio at the beginning of this webinar. I'm not going to list all of them off, but there are a lot, and I'm looking forward to reading many of them. Dr. Klitzman's received numerous awards for his work, including fellowships. He is a member of the Empire State Stem Cell Commission and the Ethics Working Group of the HIV Prevention Trials Network, and served on the U.S. Department of Defense's Research and Ethics Advisory Board. He's a distinguished fellow of the American Psychiatric Association, a member of the Council on Foreign Relations, and a regular contributor to the New York Times and CNN. So I think this is a great lead in to talk a little bit about the other side of this.
Well, thank you so much for the introduction, and it's really wonderful to be on this panel with my fellow very distinguished colleagues. It's really been a treat to hear what they've had to say, and I don't want to duplicate what they've said, but thought I'd highlight some of the ethical issues, and I'm just going to share some slides here. Can people see that? Okay. All right. So I wrote a book actually called Designing Babies, How Technology is Changing the Ways We Create Children. I thought I'd leave that as a title because it raises a number of issues. And just as background, as was mentioned, the numbers vary, but some estimates are that 10% of all men and 10% of all women are infertile. So that's about 20% of couples that need some kind of fertility services if they want to have a child. Of course, not everyone does. But as mentioned, a lot of fertile women who are people who were fertile when they were 30 are now waiting to their 38 or 40 and delaying childbirth, and they're having difficulty. There are also single parents by choice. So there are women who say, you know, I haven't found the guy of my dreams, but I want to have a child. I'm going to go do it. There are also single fathers by choice who say, I haven't found the woman of my dreams, but I want to have a child. There are, of course, lesbian, gay, bisexual, transgender parents. And as mentioned, about 2% of births in the US now use assisted reproductive technologies. In other countries, it's even higher. Denmark, I've heard a statistic of closer to 7%. But there are controversial issues. As mentioned, issues of age come up. Here's an article from the Washington Post a few years ago. A 74-year-old woman who just gave birth to twins using donor eggs. Her husband apparently had a stroke the next day and went to the hospital, and I understand never got out. But again, questions of who should have the use of these technologies. Should there be limits? What about people who want to use them and don't have insurance to use them? Again, a lot of social issues and societal issues, ethical issues come up. Another concern recently is use of CRISPR, or gene editing. So this is an article, again, from the New York Times a few years ago that got a lot of attention. Chinese scientist claims to use CRISPR to make first genetically edited baby. This is Dr. He Jiankui who did this. He created two children in which he used so-called genetic scissors to go into the embryo once it was created in an IVF clinic and actually alter the genes inside the embryo. And I would predict that we now have a few children born through him, but that in upcoming years, there may well be more of use of this technology. And I think it's something that, again, raises questions we need to think about. One concern, of course, is this raises issues of eugenics. So wealthy people may decide, I want to add a few genes that may give little bits of IQ extra points, or I want to have, 6'2", blonde hair, blue eyes as a child. Again, some of this may be more fictional than reality because genes for such traits are highly complex, but suffice it to say that people will be looking for this. And another issue is we live in a capitalist society, and there are genetic tests being peddled by companies for things that the validity of the testing isn't always clear. And eugenics is important in America because Hitler, who took eugenics to horrific ends in the Holocaust, got his ideas on eugenics from America. And unfortunately, racism is not new in America. In the 1920s, there were human eugenics fairs in the Midwest, for instance, where prizes would be given for not only the biggest pumpkin and the biggest pig, but the best pure American, read white Anglo-Saxon Protestant pedigree. So again, these are things we need to be concerned about. And as mentioned earlier as an overview, there are different kinds of prospective parents, fertile, infertile men, women, different marital status, LGBT, et cetera. Some people are at risk of transmitting a dangerous mutation. They have a breast cancer gene or a Huntington's disease gene, and will use IVF to make sure that those mutations don't get passed on. And as mentioned, one needs egg, sperm, embryo, womb. Doctors, though, vary by states, by professional context. Patients' contexts vary socially. There may be pressures on couples to, where are my grandkids? I want to have kids. And financial resources are important. Insurance is still limited for IVF and assisted reproductive technologies, as has been suggested. People want to take home baby, but again, a lot of obstacles. psychologically, socially, ethically, not just medically, and of course, a series of dilemmas, choosing meds, IVF, eggs, sperm, embryos, wombs, as we've been hearing. And this can be very stressful. There are medical stresses, social, psychological, economic, etc. I want to say one thing, which is in doing the research, and I should say I interviewed dozens and dozens of patients, providers about these issues. I was struck by how hard it is to be an infertile person. So a number of women who said, you know, I'm just not part of the parents club, that I see people I went to college with are all having kids, and here I am, I'm 32 or fill in the blank, whatever age, and I'm unable to do it, and it's really hard. When people have miscarriages, it's really experienced as a death that other people don't understand, just go get pregnant again. There's still a lot of taboos about telling people that you've used IVF. A lot of people, sex is a taboo. People don't want to say, actually, particularly men don't want to say, well, I'm infertile, I'm impotent. They'll feel they're not macho. They often blame the problem on their wife or girlfriend rather than realizing that half of infertility problems are due to men. And again, these are problems. In the past, people adopted, but that's become harder. The availability of adoption has decreased. The availability of abortion, rather, has decreased the number of unwanted infants. And whereas 30 years ago, there were adoptions from other countries, that's really no longer the case as much as it was. So as mentioned, there's a number of choices. Women who prefer to use their own eggs. Many feel that the child will otherwise feel that it's not my real mother, if it's not my genetic mother, but as mentioned, eggs decrease in quality over time. And so a number of women need to buy other people's eggs, and there are questions about how to do that, and I'll come to that in a minute. There are questions of how old is too old to use one's own eggs. And as Dr. Sauer was showing, women are less able to use their own eggs as they get older, but many still want to use their own eggs, and they'll keep trying and not want to suddenly use another woman's eggs for various reasons. They'll say, well, yes, I know there's a low % chance of success, but I'm healthy, I exercise, etc. Again, questions, how old is too old to use another woman's eggs? When is enough enough? Who decides? So there are women who say, I'm 42, I'm just going to keep paying for IVF cycles. Some doctors say, well, if she's willing to pay, I'm willing to take the money, even though the rate of success may be very low. And again, questions of whose rights should prevail here, and should there be limits? Again, there are egg agencies that buy and sell human eggs. Many clinics do this and do a wonderful job, but there are also drop-down menus online. It's a fairly unregulated industry. There's a risk of ovarian hyperstimulation syndrome that can cause side effects in some women when they donate eggs. And of course, many of you have seen ads in Columbia's Spectator and elsewhere seeking young women in college to sell eggs. Which often works very well. Some women think they'll earn money, and instead, when they have genetic testing done, they find out they have breast cancer genes, for instance, and it could be quite stressful. The other issue is, I should say, that as mentioned, people are using other people's sperm and eggs, so-called donor eggs, donor sperm. Most of those kids are not told by their parents at any point that they were created using someone else's eggs or sperm. And so people are now often going on 23andMe and finding out, oh my God, I have 50 or 150 or 12 half siblings. Mom, why didn't you tell me? Parents, perhaps understandably, don't want to say, look, we created you through a nice woman who helped create you. She gave us her eggs. A lot of parents are afraid, well, the child will love me less. The problem is, of course, that if people then find out at age 22 that their mother is not their, quote, genetic mother, they may get very upset. Why didn't you tell me, etc. So again, these are difficult issues. These are various websites. This is theeggdonor.com, and you see you can choose Caucasian egg donors, Chinese. Look at the bottom, there's Islamic egg donors, Jewish egg donors, etc. This is another website, egg-donors.com, and here there are drop-down menus of race, height, weight, skin, hair color, availability. The prices of eggs go up with the woman's SAT scores. And again, there are a number of questions of eugenics, of what are people buying? What if, and when I did interviews, people said, I went for IQ, I bought a sperm donor's sperm, who was a PhD at an Ivy League university. My kid's really bright, but he has Asperger's syndrome. And so again, people may not fully understand that what they're buying and what they may get. I'm reminded of there was a situation where George Bernard Shaw once received a letter from a very attractive Spanish actress who said, we should have kids. And she said, Mr. Shaw, if we have kids, just think our kids will have my looks and your brains. And he wrote back and said, yes, but what if they have my looks and your brains? So again, these are difficult issues, and it's not clear if someone buys an athlete's sperm or egg and wants their kid to be an athlete, and the kid doesn't want to be an athlete, let's say, or is not a good athlete. Again, genetics are not possible to always predict, and yet there is a sense of commodification or reification of some of these notions. There's another website, again, they look like escort services almost. They're blondes, brunettes, etc. Lots of makeup. So again, what's being sold here is a question. How much should eggs cost? So initially, the American Society of Reproductive Medicine, which is a wonderful ethics committee and a wonderful practice committee as mentioned, said, okay, well, you can pay up to $5,000 for an egg and $10,000 if there are reasons. They were then sued by a Japanese couple, wanted to buy an egg from a Japanese woman and wanted to give her $50,000 and said that the ASRM was engaged in price fixing. And so there are no longer caps. And again, questions of people wanting to buy, the Columbia PhD or Columbia undergraduate, A+ average, 6'2", star of the track team. Again, what does it mean as a society that people are paying more money for certain genes than others, quote unquote? Then freezing eggs, as mentioned, can help many women, but there are limitations. Sometimes also freezers are broken, for instance. It's not guaranteed. There's questions about the quality. If we've been freezing eggs for 10 years, what are eggs going to be like in 20 years or 15 years? There's not a lot of data. As Mark mentioned, Dr. Sauer mentioned it, will there be a sufficient number of eggs? A lot are never used. And a lot is driven by companies seeking profit. Facebook and Apple want young female employees to stay working for them. And so they'll say, well, we'll pay for freezing your eggs. A lot of women think, wow, I don't have to worry about it now. But as Dr. Sauer said, they may not freeze enough eggs. The freezer may break, etc. So again, few guarantees, and one needs to be aware of, is profit motive driving a lot of what's happening in this space, or more than it should in certain ways? We live in a capitalist society, that's a reality, but we need to be aware of some potential limitations. Again, sperm banks help many people, but are often unregulated, anonymous. I mentioned problems with 23andMe. One shouldn't, a sperm bank shouldn't be creating too many children from any one sperm donor, but it's really on the honor system. A guy can go to different sperm banks and say, oh no, I've never been a sperm donor before. And there is a gentleman in Great Britain who has created over 800 children. He's very proud of that fact. He wants to get to 1,000. And again, these are questions about what ethics and policy should be in these spaces. Pre-implantation genetic testing is now used, as mentioned. It can help choose embryos to avoid certain diseases, cystic fibrosis, Huntington's, breast cancer. We can now say we're not going to use these embryos that have the genes for these diseases, which can be very important. Genes do manifest themselves differently. There are some infertility doctors know a lot about genetics, some less so. Some internists and pediatricians know less about it. There's also all kinds of new genetic tests that we're developing, and there's not much regulation about this. Again, regulations can be a double-edged sword, but these do raise questions we need to think about as a society. Again, genetic markers vary. We can all have a gene for cystic fibrosis. Sometimes kids will be perfectly healthy. And again, there are debates about, should we be eliminating, if people have genes for autism, for instance, should we be not passing those genes on, for instance? And again, there are larger debates about this we can talk about. Again, providers vary in how much they've done. One IVF doctor told me, I've had patients come in with diseases I'd never heard of. Again, every year we're discovering new mutations that cause different diseases that we could test for. Not all are equally penetrant or Some may cause severe disease in some people, but often not cause any disease or very little disease. And there's often, we have a limit in the number of genetic counselors we have in this country, the number of geneticists, and so there's often a lack of understanding about the nuances. And again, cost could be quite high. Some patients may say, look, I know I'm at risk of breast cancer or Huntington's disease being passed on, but I just can't afford the $50,000. We'll just have to take our gambles. The other issue is that the wealthy are now able to increasingly use pre-implantation genetic testing to, for instance, make sure that breast cancer genes don't get passed to the next generation. The poor can't afford this. And so increasingly diseases like breast cancer may become more diseases of the poor because wealthy people were able to screen out the genes. Also issues about what else to choose embryos for. So again, family balancing. There are people who say, I only want a boy, we'll only implant boy embryos or transfer boy embryos. A study I did showed that clinics that were affiliated with academic institutions tended not to do this, whereas freestanding clinics, or not to advertise it, freestanding clinics, private clinics did this much more. There are cases, some are somewhat apocryphal, for instance, of a deaf couple saying, I want to have a deaf child, or a dwarf couple saying, I want to have a dwarf child. And again, questions come up. I would argue that the unborn child is a right to a so-called open future. But again, you can imagine the kind of questions that these raise. We talked about paid gestational surrogacy. Again, this started in the 1980s. Initially, for many years, up until about 2 years ago, it was legal in several states, most notably California, now New York as well. It can help gay couples, women who are unable to carry the pregnancy. But interestingly, when it first came up in New York about 3 years ago, about 6 months before COVID, when the New York State Legislature debated it, it was passed in one branch of the New York State Legislature, but not the other. Gloria Steinem and other feminists came out concerned about exploitation, that would women be brought into this country to be serving as gestational surrogates? Would there be human trafficking? And of course, it's been in the paper recently that Ukraine has become, up until the recent war, horrific as it is, Ukraine was the major site of couples going abroad to hire a Ukrainian woman to carry their child. And of course, there are now kids stuck in Ukraine whose biological parents are elsewhere. But again, a number of feminists push to have residency requirements for surrogates in New York. You're to live here for 12 months. That was not part of the final legislation that went through. Again, there's very little data about it, who these women are. Are they poor women carrying children for wealthy women? By and large, they are. That in and of itself isn't a concern, but it's something we need to be aware of. Again, there are, as Dr. Sauer mentioned, tests that are introduced and become popular in many IVF clinics that may not, the safety of which has not yet been fully proven. One example was intracytoplasmic sperm injection, which was meant to help men who had low sperm counts, was soon used in 2/3 of all IVF. And more recent data shows that it increases the risk of cognitive deficits 2.5 times. So again, there's a need for data and evidence-based practice, which often occurs, but not always. And then how much is a child worth? Couples debate this. Some couples say, we've emptied out our entire life savings to have a child. We're in our second IVF attempt. Hopefully this will work. We want to hire a gestational surrogate, but the costs run up quickly and couples may disagree. So basically, these technologies are creating new families, which is wonderful. They're helping to avoid certain diseases among offspring, which is terrific. It's also changing our species, or beginning to change our species. And again, maybe only 2% now, but increasingly, given that 20% plus of couples are, numbers will probably increase. I think we need to think about the ethical implications, consider the rights of unborn children, larger social justice issues, questions how much we should be concerned about eugenics, about social justice, about, for instance, diseases like breast cancer becoming more of a disease of the poor. Should there be limits of patient choice? Who has rights to infertility treatment? How much? Should there be oversight more? Should government get involved more? Of course, these are problems given the religious right at the moment. There are sustainable concerns that if government does get involved, given what's going on in Texas around abortion, women's rights may not be as protected as many of us would like. one would hope that there would be possibilities of having some incremental improvements. So I can talk more about that. And I think more guidelines and policies. ASRM has done a terrific job. I think there's more they could do. The CDC collects data, or rather it asks clinics to IVF clinics to provide, but it's voluntary. And the amount of non-reporting has been going up in recent years. And I think that's of concern. I think at least knowing what's going on in the country in terms of getting more data would be important. Are women being exploited? Again, we don't know. And as gestational surrogates, I don't see a lot of evidence of that, but there are feminists who tried to block what Governor Cuomo did a few years ago, and it'd be important to get more data. As I said, the data collection now is voluntary. We don't know much about egg donors, for instance, surrogates. I think there should be more requirements. ASRM comes up with guidelines, but they don't have enforcement power. And a lot of clinics are not following ASRM guidelines. I think it'd be great to have registries to keep donor gamete records also, which has recently become recommended. But again, I think it's a problem that kids who were created through donor eggs and sperm mostly don't find out through their parents that they were created that way in the United States. Now, Great Britain has outlawed anonymous donation. In Ireland, everyone at age 18 has a right to their birth certificate, lists whether there were donor eggs or sperm used, and if so, who the person is. Medical history of one's genetic parents is important for knowing your own risks of various diseases, so it's important data to have. Again, egg agencies, I think, need some oversight. We need to track some of this better. I think we need caution using new interventions if there's not good evidence. Profit motive is part of our society, but we need to be careful that it doesn't drive a lot of what's done too much. And again, use of CRISPR, I think, is another issue. The status quo doesn't bode well for our abilities to oversee CRISPR use, that is gene editing of embryos in the future. I think it's something that's coming up in the questions when it's safe enough, etc. But we need to be careful, and people, again, travel to countries to have things done. So even if we don't have CRISPR done here, it might be done elsewhere. Again, need for more research. That's the book, and I'd be happy to answer questions. And again, thank you very much for inviting me to speak as part of the panel, and I look forward to the Q&A.
Excellent. Wow. So for anybody listening to all of this, this is a lot of information, and you know, extremely excellent presentation from everybody. And you guys did such a great job analyzing all different efforts. So there's a million questions we could ask. So we have some questions. And if you would like to put a question in the Q&A that I can read out loud and our panelists can address, please feel free to do that now. We have a couple questions that we've already answered, which they're not great answers, but the first question we had was, are most of the clients and patients that we're working with of higher income, and are these issues being dealt with by people of all economic levels? And Dr. Sauer wrote a very good response. It's very hard. ART is expensive, it's under-resourced, and there's definitely a lack of access to this care for all populations of patients. I think if all else was equal, I think that would not be the case, but it really is not a fair event. Yeah.
Yeah, so there actually is an article in the New York Times yesterday about a gay couple who has sued New York City because they were denied IVF coverage. And I think that this is an area in which litigation and such lawsuits and popular opinion can move the needle potentially. So we can talk more about that.
No, I agree. I'm actually part of the Bar Association of New York and the Women's Bar, and there was, as you said, a lot of debate regarding how to protect surrogates who are potentially financially motivated to carry babies for more financially advantageous situations. And you'll be happy to hear, Dr. Klitzman, that there's a requirement for life insurance for the surrogate. There's a requirement for medical insurance. There is counseling. There's a requirement for the surrogate to have her own counsel before an agreement can be signed. There is some financial benefit to the surrogate, and there are many women that enjoy being pregnant and find it very rewarding to carry babies for other infertile couples. And what we're seeing right now is a lot of family members that are carrying babies. It's compassionate surrogacy. But we're seeing a lot of family members donating eggs, or friends donating eggs or sperm. A lot of platonic friends want to help other friends become parents. So I am not seeing, not yet anyway, situations that I think are really financially exploitive. And I think everyone's very concerned about that. Again, these orders have to go through the court system. They have to be signed off by a judge. There is oversight. And there's very, it's a growing demand for surrogacy contracts, but a lot of people are doing agreements, egg donor and sperm donor agreements and frozen embryo agreements. I mean, the floodgates are opening on that score. So I share your concern.
Yeah, so thank you for those comments. So paid gestational surrogacy in the US far outweighs the amount of altruistic, I'll carry it for a friend, many times. And there is extremely little data. I did a look, and there's no study that looks at more than 30 women who've been gestational surrogates about why they're doing it. Are they of different race? Generally they are. There's going to be an economic difference. But we really know very little about, how do women, there's zero studies. How do women who are paid gestational surrogates look back at the experience 5 years from now? Zero. So I think there's a need for, I happen to think that there's not a lot of regret out there, but it'd be good to know.
Yeah, it's entering the mainstream. We see celebrities doing it. Quite a few celebrities have done it successfully. And really, it's the stigma that's falling away that is really making it more of an option that I'm sure all of the doctors are going to hear about, and we're going to start to talk more openly about. Tamara, there was a question that someone posed regarding the rights of the mother and custody dispute, which mother has better rights? And I can answer that question. In a custody dispute between the surrogate who's carrying the baby versus the parents that are contracting with the surrogate, that is the point of having a legal agreement where all the rights are spelled out. And it used to be that people were very worried about the obligation to pay child support. If I donate sperm and I'm the biological father, am I going to be now liable for child support? And the answer to that now is no. As long as you have an agreement and everyone is legally represented and you're just donating sperm or donating an egg, you do not have a child support obligation anymore in New York State. It does have to be an agreement that's drafted in a certain way, and there have to be counsel on both sides in most cases. The surrogate is surrendering her parental rights. She's surrendering her legal rights of custody. So this is all brand new in New York. So that answer, that question has an answer that I can give unequivocally. So thank you for posing that question.
There is a question that says, this person that asked is someone who teaches about ethical issues. What's the latest information about the sequela of, and I'm not sure that it could be hyperstimulation, especially regarding surrogates and their knowledge about the possible risks, but I think that means also stimulating. What is the risk of a woman, either surrogate or patient, that's being stimulated? Are there future risks in their life for going through these processes?
I think Mark gave a good answer there, or Dr. Sauer.
Yeah, I mean, it's a tough question, again, because the data is hard to really decipher. I mean, you're going to find, depending on your viewpoint, support against or for long-term health issues. Back probably 30 years ago, there was a huge fanfare that these drugs increase your risk for ovarian cancer. That's largely been dispelled, but not completely. Again, I don't think we have very good data. We have a lot of good short-term acute data, complications from stimulation, complications from aspiration. And they're reasonable risks, but it's not without risk. My concern about the ethics of all this, whether it's a patient with her own eggs or an egg donor, even more so, is a matter of true informed consent. Who's delivering it? Typically, it's not the doctor. It's commonly the clinic, oftentimes standardized forms by nurses, PAs. And you know, I've always been impressed when you have a problem later, usually somebody in the hospital is pretty sick. That's when these questions, suddenly there's damage control, right? So again, I tell patients basically, I mean, again, the good news is there's such resources with the internet now. You can get a lot of information, pretty good information about this. But from a position of physician related informed consent, I think we're not very good at that.
Agree. We have a bunch of questions coming in, so I want to make sure we get through some of them. Is a question for Dr. Klitzman. How do we know that most kids conceived with donor eggs and sperm are not told about it? Where can we read more about this?
Yeah, so this is what a number of studies have shown. There's very good work by a woman named Susan Golombok, G-O-L-O-M-B-O-K, who was at Cambridge, for instance. She actually just retired about 3-4 months ago. But there has been both, this is the sense that clinicians themselves who I've interviewed have had, and this is what the data suggests.
Okay. I'm just trying to type her name in here. So
recommended. It's recommended that parents do begin to tell, but the situation is that generally does not happen.
There's a patient that says one of our participants is a single mother by choice with IVF and a donor conceived child. My life has crossed paths with much of what's been talked about today, to the issue of parents not telling donor conceived children about their history and half siblings. I think and trust that this is changing, that there's a trend towards being more honest and open with kids as SPCs and donor created families and IVF become more common.
Yes,
I don't know if anybody can comment on that.
Let me just qualify what I said earlier. Obviously, if kids who are born to a heterosexual couple are many are not told, my sense is most. It's very different if it's a gay couple, a single parent by choice, or obviously there's someone else who helped create the child who was not one of the parents. So what I'm talking about is really sort of heterosexual couples who decide to use donor egg or sperm. So I would hope that it is changing. I think that 23andMe is creating pressure. And I think the ethics committee of ASRM after 23andMe sort of began to reveal a lot or lead to people finding this out, did come up with guidance that recommended that parents be encouraged to disclose, but in the end, it's up to the child.
Yeah, 23andMe is causing all kinds of situations, legal situations too, including estate planning and estate litigation, because heirs are coming out of the woodwork, and a lot of times it's from a family member that has donated, data given data to 23andMe, and then other family members are coming forward and saying, "I think I'm related to so and so." I have a case in my office where a man in his 60s donated a lot of sperm when he was a college student, never told his wife, and now there are potentially 20 children of his from the sperm he donated, and it came out through 23andMe because this person's brother was in the database. So this is, I think, going to be more regulated. This is definitely going to be a concern. There are privacy issues. A lot of people are concerned about privacy. And in this particular case, this client was very concerned that these young people were going to come forward and claim part of his estate, which is not so easy to do. But there are a lot of ethical issues that come out in other areas, and this is an industry that has to be regulated. There was a question about, are there going to be limits on how many eggs can be donated or sperm? Right now, I'm not aware of any limits. I don't think there are, but I defer to the doctors. I think that's coming. That's going to be coming. It has to be.
So I want to answer two more questions, because two of the questions are actually very similar. They have to do with embryo adoption. So couples who have created embryos, and whether or not they decide 5 years, 10 years down the road, they're not going to use them, how can they go about? Can other families adopt those embryos?
My understanding is only if the couple that created them legally allow it.
That's correct. Most clinics require an agreement between the two parties that donated for the embryo, and they have to be clear about what happens in the event of their death. Are these embryos going to be disposed of at a certain point? And they're also very concerned about who's going to pay for the storage. So all of this is in writing to protect the clinic, to protect the rights of the couple. And yes, they can both agree that the embryo can be donated to a third party. And sometimes they do agree to do that, or donate it for research. I've also seen that as part of an agreement.
I should say there are court cases that have come up, some well publicized, where a couple will create embryos and then divorce. And one member of the couple wants to use the embryo and the other doesn't. And my sense is, certainly up until recently, the sense was that both parties had to agree. I've heard that there are some states that have recently allowed, red states, where if one person wants to use the embryo, the court has let them.
Yeah, in New York State, and this is exactly why it's such a painful issue. There are couples that have suffered with infertility, have gone the lengths of creating embryos, then they get divorced, and they're usually a little bit older, and there's a sense, usually by the woman, that these are her children. These are embryos. These are her future, offspring. And in the event of a divorce in New York State, there has to be consent by both sides. And it's a very, very painful outcome in many cases. The law is very clear in New York, but you're right. It is tied to the abortion issue, the pro-life movement. In other states, there are very, very different outcomes.
And in terms of donating to the clinic, so at the clinics that I've worked with, there's 3 options for when you have supernumerary embryos. The first is to discard them, the second to donate to research, and then the third is to donate them back to the clinic. And so you can actually donate your embryos to the clinic, give up all your rights to those embryos. And then we have that option when we're counseling patients who need donor egg, donor embryos, to be able to offer that. It's much more cost efficient, because donor egg from these egg banks, it can be $10,000, $15,000 for a lot of eggs. We don't charge for the embryos, so the embryos are essentially free, and then you pay for the frozen embryo transfer. And so it's an opportunity for patients that may not be able to afford the donor services to be able to have a child.
Okay, so I just one more question. Alice is definitely encouraging us to end this because it's so interesting. We could talk forever, but I want to ask this question from the audience. What are the current practice of choice and trends among LGBT couples and single couples seeking the best options?
Well, obviously it depends what they need. So, if they're lesbian, gay, et cetera, so single or couple, but IVF has led to the creation of thousands and thousands of children for LGBT couples, and they're very loving parents. I should add that Susan Galamba, who I mentioned earlier, has done research that shows that LGBT parents, by and large, are actually better parents because they really want to have the kid. They don't accidentally get pregnant and be stuck with some kid, and what do we do with this kid? So just FYI. So I think that there's a lot of opportunity.
And there's a lot of choices. I mean, that's actually the best thing about all this technology, is that there are choices now, whereas many years ago these couples didn't have choices. So I'm going to hand this over to Alice. She's going to wrap it up for us, but I thank everybody so much for your participation.
Thank you, Tamara. I am so sorry to cut into the interesting discussion. I promise we'll have more time to go through all of that later. Thank you so much, Tamara. Thank you so much, our panelists, Dr. Goodman, Dr. Sauer, Dr. Klitzman, for this amazing conversation. As mentioned, we actually have an opportunity to actually keep the conversation rolling. I think there should be a link coming up soon in the chat box. There it is. So feel free to go to that Zoom link after this meeting is over. Our Columbia College women volunteers will have much more intimate conversations because I'm sure we all have so many other topics that we want to discuss. This is definitely a very important topic. I also wanted to take the time to thank the Columbia College women board members and the volunteers that helped make this happen. So Maria, Deborah, Liz, Lee, Jackie, Nikki, thank you all so much. And for everyone else attending, please join us for reunion weekend. So that's starting Thursday, June 9th through the 12th. CCW will actually have special programming throughout the entire weekend, so keep an eye out for that, especially if you want to keep chatting about stuff like this. All right. So I think we can all just navigate over to the next Zoom link and we can keep the conversations rolling there.
Thank you.
Thank you.
Thanks,
Thank
everyone.
you, everyone.